near, and originally I did not want to study, but you know, my death is coming, so I have to be quick. And you know, since the past few streams, you know me, I've been, you know, like working on you know, my job and stuff, so I didn't really have a chance to study. So let's just remind ourselves with, you know, with my academic needs, okay? Stroke. Fever is harmful. Okay, of course. Treating infection is always priority. Common measures for control of central fever. Antipyretics. Acetamine. Acetaminophen. Okay, acetaminophen. Okay. Common measures. External cooling, cool guard, endovascular cooling, Coreticool, thermoregulatory reactions, vasoconstriction, shivering, impaired cooling efficiency, patient discomfort, may need sedation sometimes. 28 to 34 degrees is neuroprotective, okay? Baby, baby, baby. Let me see. I think the stream is working. It's just that stream manager is being a little bitch. There we go. Okay. I really wanted to stream Genshin again, but you know, next week I will be busy, you know, in packing and unpacking stuff. So, you know, probably streaming would not be that available, but I'll keep you guys updated, okay? Target temperature management. Post cardiac arrest. Oh shit, I forgot. I totally forgot about my stuff, okay, in Genshin. I need to spend some of those resins. Spend the resins. Very important. Okay. Pulmonary complication. Decreased conscious state. Okay, sputum retention, aspiration pneumonia, atelectasis, neurogenic pulmonary edema. Okay. Desaturation, okay, second severe neurological insult. No idea why, but okay. Okay, let me kill the boss once, and you know, I'll quickly refocus myself onto the study stream. Okay, you might be able to hear some you know, background noises of Chlorine like Clorand you know, fighting in the background. The Nahida, okay. Kazuha, okay. The Lali. Okay, go Clorand. Okay. Come on. Kill everything. Come on. Once the Lali is here. Temple of Wisdom. Okay. Okay, plug on. Okay. Come on, come on, come on. Kill all of them. Hold on. Go. Kill it. Aggravate. Come on, come on, come on, come on. Okay. Make yourselves at home. Okay, just fuck it. Okay, there we go. Okay. Use it. Okay, and I will always love you. Come on, come on, come on, come on. Hunt them down. What? Come on, come on, come on, come on, come on. I'll just fight one more and I'll be continuing my body state. I'm already losing focus. Okay, the Temple of Wisdom. What? 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 Time to testify. What? Kill it. Kill it with fire. What the hell? Go, 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 go. We don't have much time. Kill it. There we go. 1314 damage. Okay. Okay, let's blink back to a statue so we can heal. It's very important to heal, guys. Okay, okay. Neurogenic pulmonary edema, respiratory failure, intubation, or you know, or tracheostomy. 11. Yes. What is this? Claim rewards. I'll claim tonight. Okay, leave right now. Mechanical ventilation, chest physio, tracheostomy. Okay. Vocal cord policy. Improve comfort and reduce need for sedation. Really adjusted ventilatory assist. Okay. Doing NAVA, positive pressure is applied to airway opening in direct proportion of the EDI amplitude. cardiac complications, ventricular arrhythmias. Okay. Neurogenic stunning of myocardium, heart failure, cardiogenic shock, echo ECG, okay. A-line urine output and cardiac output, treatment cautious fluid, inotropes, vasopressors, hyponatremia, not enough urine. Hypernatremia, exacerbate brain edema. Electrolyte abnormalities. Failure of release of ADH from hypothalamic pituitary axis. Inability to concentrate urine. Okay. Pituitary surgery. Lace water. Metabolic complications. Glycemic control. Oh my god. Medical complications, thrombotic and embolic complications. Absence of prophylaxis is high. Okay. VTE prophylaxis is important. IPC. Graduated compression stockings. Mechanical devices are recommended. Continued until ambulatory. Heparin prophylaxis. Okay. Healthcare-associated infections. Invasive device use, increased morbidity and mortality. More resistant organisms. Increase in antibiotic use. Nosocomial EVD. Prolonged placement. Okay. What's that? No? But there we go. Next one. Just a quick recap. Stereostatic radiosurgery. Okay. We have to be quick. Be quick. And critical care. Okay. Radiosurgery. Okay. Radiostatic surgery. High precision, high accuracy. Rapid fall of radiation dose at periphery of the dark target. High dose conformity. Direct damage. Ionized DNA causes double or single strand breaks in direct damage. Stereostatic radiosurgery. Conventional radiotherapy. Repair, resortment, redistribution, repopulation, and reoxygenation. Sublethal. Repair of sublethal damage in normal tissue between fractions lead to a future radiation toxicity. Okay. Radiation introduces a block of cells in G2 phase. Okay. Which leads to synchronization. Okay, repopulation. Reduce acute side effect. Reoxygenation. Okay. Conventional therapy. Okay. What's that? Stimulating cell. Does it stimulate surviving cells? Okay. Fractionation. Surviving cell. Okay. Time. Okay. Treatment. Patient eval, imaging acquisition, treatment planning, position. Okay. Can do that. Patient eval, imaging acquisition, treatment planning. Okay. Machineries, Linac. Tomotherapy, cyberknife, gamma knife. Okay. Photon therapy. Brax peak. What is this? Proton therapy. Damage occurring to surrounding tissue. Okay. Okay. A machine move in an arc during treatment. Patient open brain. No idea. Machinery, cyberknife. Okay. More precise, need more planning in space, so... Okay. Cyberknife. It's just showing me pictures. Gamma knife. Provide high precision. Okay. Photon knife. Large accelerator. Lordy. Gemini photon therapy. Okay, indication cost. Immobilization techniques. Invasive, non-invasive, frameless, frame-based. Okay, no idea what it's talking about. Okay, frame-based. Frameless. Okay, so there's like a mold. Dosimetry techniques. Conventional art therapy with circular collimators. I have no idea what it's trying to do, but okay. Structure localization, lesion localization, beam positioning, dose planning. Okay. Structure localization, lesion, beam, dose. Okay. Neuroradiologist, radio-oncologist, medical physicist, and neurosurgeon. Okay. Benign tumors. Acoustic neuroma, meningioma, pineal, and pituitary tumor, metastatic brain tumors, vascular lesions, AVM, trigeminal neuralgia. Okay. Acoustic neuroma. Stereostatic radiotherapy is a viable treatment option for selected patients with smaller tumors or for enlarging tumors in patients who are not candidates for surgery. Okay. Facial and hearing preservation. Tumor control rate 80 to 90%. Okay, but better hearing preservation and much lower rates of trigeminal and facial neuropathies. Acoustic neuroma. Okay. Static radiosurgery also appears to be a reasonable treatment alternative for patients with acoustic neuroma associated with neurofibromatosis type 2. No idea what that is. They think that I know. Acoustic neuroma. Diffuse margins, unable to completely removed by... Okay, that. Largely bulked by surgery. Tumor managed with SRS associated with ataxia with cellular symptoms. Effects aren't immediate. May take a few years to improve or worsen. Okay. Meningioma. Constitute approximately of 20% of all primary intracranial tumors. Complete surgical resection, if feasible, is the standard of care. Okay. SRS can deliver for the treatment of meningiomas that are unresectable, recurrent, or residual after surgery. Okay, so it's like an adjunct or something. Like resect it, then cut it off. Local control ranges from 70 to 100, 75 to 100%. Okay. Induced necrosis or edema may occur after SRS. Okay. 30% with the mean dose being 29 GY. I don't know how do you pronounce GY, but well. Mean dose being 29. Pituitary tumor, okay. Endocrine improvement rates were much lower. Decrease in hormone hypersecretion could be seen. The earliest 3 months, but could extend up to 8 years after SRS. Normalization frequently within the first 2 years. Reported toxicity associated with SRS for pituitary are below. Rate of optic neuropathy was 0.9%. Rate of permanent cranial nerve deficits were 0.4%. New trigeminal neuropathy was reported only 0.2%. Brain met. Compared with surgical resection, SRS has the advantage of being able to treat surgically inaccessible lesions and multiple lesions. Smaller than or equal to 3 to 4 cm are regarded as suitable. Okay. Local tumor control rates are far greater than 80%. Okay. Patients up to 4 centimeters, newly diagnosed brain met. Boosts the whole brain radiotherapy significantly improves local brain control rates as compared with whole brain radiotherapy alone. Okay. Boost with whole brain. Okay, so it's an adjunct. Improve control rates. Okay, did not result in improved survival. What? Local brain control rates. Okay. Whole brain radiotherapy also results in a much higher incidence of decline in learning and memory function by 4 months. AVM. Just ablated. Okay. Surgical excision. Brain area. Eloquent brain area. Obliteration rate with SRS depends on lesion size, radiation dose, and time. Trigeminal neuralgia. Okay. Okay. Brain-related. Pain, bleeding, fracture, and infection can occur in pin site. Seizures. Brain edema. Other acute symptoms. Headaches, nausea, vomit, fatigue, vertigo. Okay. That's weird. What in the fuck? Okay. More concerning. Okay. Optic neuropathy. Risk of developing clinical significant radiation-induced optic neuropathy was 1 to 2% for patients receiving 12 GY or less. Other cranial toxicity. Cavernous sinus appeared to be quite resistant. Risk of permanent 3, 4, and 6 neuropathy and 5 neuropathy was 0.4 and 0.2%. Radiation necrosis, vascular injury. Alright. Precision and focused delivery of single high dose of radiation in single session. Intracranial and skull-based lesions with results comparable to surgery in some tumors. High conformal in isodose distribution and a very steep dose gradient of dose fall-off beyond the prescribed isodose line. SRS lend themselves well to the delivery of an ablative dose of radiation to intracranial and skull-based lesions. Serious late toxicities associated with SRS are in general low. Okay. Fuck me. Okay, next. Is it IBM? Is it IBM time? It is IBM. Okay. Well, time to go, yo ho ho. Ho ho ho, motherfuckers. Book stuff. Okay. Brr, brr, brr. Oh, Lord. Oh, oh, ADM, Russell and Rubinstein. Dysplastic vascular malformation. Cavernous angioma, capillary telangiectasia. I don't know. I don't know if that's how you say. You will find that the world has changed forever. Okay. Wait, let me Go crazy when there's no work. Oh, let me. Can I like find a gift? Uh. Oh my god. Okay, okay, okay. God, DVA. What the fuck is a DVA? I forgot. Neurovascular diseases. Okay, etiological classification. Okay, blah blah blah. What the fuck? What the fuck are these? Proliferative angiopathy. The DSM. Well, we'll see. Aneurysm. There we go. Intima. Okay. There's no endothelial cells, really? Fragmented internal elastic lamina. Internal elastic, okay, fragmented. Okay, adventitia. Okay, wait, congrats. It's okay. Aneurysm, morphology. Okay, saccular and fusiform. So it's like berry shaped, and there's the fusiform, which is like the entire vessel is the aneurysm. Trauma, tumor, inflammation, hereditary, atherosclerotic, dissecting, like vessels and saccular. Okay, anterior posterior. No idea. Read this. Unruptured aneurysm. Okay. Treatment option conservative. 127 slides. Fuck me. Okay, let me be faster, okay? Otherwise, I'm not going to sleep tonight. Cavernous ICA. A 5-year cumulative rupture rates. Okay, 0.6, no, 2.6, 14.5, 50%. Okay, the bigger the size it is, the more dangerous the dangers of the aneurysm popping. Oh god. Oh my lordy. Unruptured. Oh my god, they're showing me papers? Oh, fuck. Okay, treatment considerations. I'm not gonna read the papers. Fuck them. Phases, preference. Treatment risk, durability, natural history. Okay. Aneurysm location, shape, symptoms, radiological progression, surgical team capability, morbidity and mortality record. Oh my god. Recommended for familial aneurysm. Okay. Oh my god, I hate like short forms. Okay, I can't read. First degree relatives 2.4%. Second first degree, what? 2 first degree relatives 10%. So if your parents have aneurysm, then you're quite likely to have aneurysm as well. So one parent 2.4% of having aneurysm, while 2 parents increase your rate by another 10%. So 3 to 5 years interval to interval, what? So 70 years old. Ew. I have forgotten password long time ago. And you know, ever since we left Runel, okay. Never watched. Okay. Aneurysm. You know what? You know what? You know, this whole exam and work thing is giving me an aneurysm. How about that, okay? You know what is the, you know, the first best prevention of getting an aneurysm? You know, not working and not studying. How about that? Have they considered ever putting it in, like, on the presentation? Maybe they can do, like, a research program, like, you know, like, get a bunch of people who does not need to work and a bunch of people who has, like, stressful life with, like, work and school. Then, you know, and another controlled group of whatever that is, then, you know, put them in a room and, you know, check their blood vessels and see if they have aneurysm. Okay, I'm gonna get like a Nobel Prize for for medicine or something, guys. Sign me up. Okay, and join my research team. We will find the truth, you know, the key to health and success. Ruptured aneurysm. Jesus Lord. Sadly, I'm sharing account. Okay. Lol. Oh my god, hemorrhage basics, okay. Meningismus, coma, hypertension, focal deficit. It's like a stroke. I only watched season 1. But if I recall correctly. Oh my god, 15 more minutes. 15 more minutes and I'm dying. Okay. Grading. What the fuck is this? Common grading scales for patient with subarachnoid hemorrhage. Ew. Ew. Why did I choose to become a healer? Okay. The pain, it's not worth it. Moderate to severe headache. Nuchal rigidity. No other neurological deficit except cranial nerve palsy. Drowsiness, confusion, mild focal deficit. Stupor. Moderate to severe hemiplegia and possibly early decerebrate rigidity and vegetative disturbance. Sheet. Initial management is ICU, nil by mouth, prop up 30 degrees, 2 lit O2. IVF. Okay. IV fluids, normal saline plus 20 millimoles of potassium chloride. Okay. Keep blood pressure less than 140. In-output monitoring, fully to blah. Routine blood checks, chest x-ray, ECG. What's a CCB? I forgot. Calcium channel blocker. Jesus, I hate their short terms, like short forms. Mimics, hyperdensity. Gosh, dead me. Definitive treatment. Oil. Okay. Coil and clipping. Treatment choices depends on etiology. Coiling. Flow diverter. Flow diverter, intersaccular flow disruption, apparent vessel occlusion, or bypass. Okay. I miss having people in here. Impact Sailor, multiple comorbidities. Dabigatran. Who the fuck is CT done. Small suprasellar irregular roundish lesion at the right of tuberculum sellar region. Is it this one? This is the left though. Maybe this one. Maybe this is it. Okay. Left pupil distorted after surgery. Right side 3 centimeters reactive. No squint, no diplopia. Okay. Oh my god. So it's just... Oh, AVM. There we go. Lordy. Okay. AVM. Outline. Introduction and epidemiology. Natural history of AVM. High flow vascular lesion that consists of a tangle of abnormal blood vessels. Just ablate them. Come on. Feeding arteries, draining veins, nidus. Conglomeration of numerous AV shunts without interposed brain tissue and no capillary beds. Absence of capillary beds. Low resistance, high flow AV shunting. Fistulas. Um, 9% in all subarachnoid hemorrhage, 4% in all intracranial hemorrhage. Ugh. Natural history. Risk of hemorrhage 2 to 4% per year. 10 to 15% mortality from each bleed. 30 to 50% morbidity. Okay, rebleeding risk. 6 to 30% first year after hemorrhage, then declining. Okay. Ew. Fuck me. Presentation. How to stop studying? Help! Teacher, headache, neurological deficit, asymptomatic pediatric. It's just like, you know, a hemorrhage in your brain. It's just that. It's not that much different. Mm-hmm. Mm-hmm. Grading system of AVMs. Small, medium, large. Eloquent of adjacent brain. Venous drainage pattern, okay. Speltzer and Martin grading system. AVM grade equals size plus eloquent of adjacent brain plus venous drainage pattern. Grade 1 to 5. Grade 6 in operable case. Okay, major deficit, minor deficit. Spetzler. Risk of surgery. Minor deficit, major deficit. Favorable outcome. Okay. I don't want to study no more. To treat or not to treat? Risk of hemorrhage and risk of intervention. Oh my god. Higher bleeding rate. Spetzler grade 1 and 2. Small size periventricular nidal aneurysms and heat as fuck. Thermostatic radiosurgery. Embolization. Embolization. Ah, yeah, they do inject some kind of embolizing agents to block the whole AVM. Okay, surgery, combination, conservative. Ablation. Okay. Gamma knife radiosurgery was used to treat AVM. Obliteration is a process resulting from endothelial proliferation. Endothelial proliferation, within the AVM blood vessel wall, supplemented by myofibroblast proliferation. Leads to contraction and eventual obliteration of the AVM blood vessel. Latency 2 to 4 years. Okay. Obliteration rate 50 to 95%. Okay. Case scenarios. I ain't gonna watch that. I'm gonna read embolization. There we go. Onyx. Okay. AVM after minor head injury. 3 cm laceration wound, no focal deficit. Speckled calcification. Okay, whoa. This whole like jumbled up thing. That's the AVM. Okay. Followed by surgery. Oh lord. Okay. 19 loss of consciousness with limb twitching. Left frontal AVM. Okay. I don't know how to, interpret a DSA. Jesus. No residual AVM. No seizure on Keppra. Resumed work. Okay. Inoperable. Dizziness as well as on and off right upper limb weakness. Dropping glasses and chopsticks. Root to her face and neck. Chest clear. Okay. Cavernoma. What the fuck is a cavernoma? Vascular malformation composed of clusters of thin-walled immature veins. Sinusoidal cavernoma with no intervening brain parenchyma. Red, purple, blue, multi-lobulated, often compared to a cluster of mulberries. What? Oh, Lord. Less than 2% per lesion per year. Acquired. Supratentorial, brainstem, cerebellum, cranial nerves, and spine. Familial disease. Symptomatic in their lifetime. Okay. Seizure, headache, neurological deficit. My classification. Treatment options. Indication of treatment. 91% seizure free. Repeated bleeding. Case scenarios. Where is the... Okay. First bleed. Ooh. Oh. Okay. Functional MRI. Awake craniotomy. Full power still on dilatine and epilim. Gradual. Frontal mass with surrounding edema. Receptionist walk unaided. Okay. DVA. I forgot what a DVA is. Most common intracranial vascular malformation. Anatomical incorrect but physiological normal. Venous outflow pathway for involved heart. Intrauterine... Uterine ischema? What? What does that mean? Intrauterine. So it's a pediatric thing. Contrast CT linear, curvilinear enhancement. MRI hypo intensity on T1, T2. Contrast enhancement. DSA. Okay. Caput medusae. No idea what that means. Flow related. Arranged pattern of medullary veins converging centrally on a single draining vein. Thickened and hyalinized. Found within normal parenchyma. Seldom symptomatic. No treatment needed. Association, cavernoma, migration, anomalies, sinus pericranii. Also these kind of things. Okay. Pathomechanisms of symptomatic DVAs. Okay. Rare cause of hemorrhage. AVF dural AV shunt. Oh my god. Arterioventricular fistula. Dural arterial supply to dural venous drainage channel. Post-traumatic acquired. Conservative surgery, endovascular treatment. Transarterial. Okay. Trigger, clinical presentation, evolution, benign. Represent converted to aggressive type. Aggressive. Annual risk for death, 10%. Okay. Shot locations. Venous drainage patterns, multiplicity. Venous congestion, infarction, hemorrhage. Classification. Impaired outflow, dilatation of vein. Okay. Hypersignal, hemorrhage, reflux to brain. What? Arterialization of veins. What? Focal venous ecstasias. Keys to obliterate the fistulous connection whilst limiting adverse outcome. Transarterial approach. Identify all feeders. Choose the most direct. Meningeal osteodural. Okay. Identify dangerous vessels. Determine target. Liquid embolic materials. Onyx and glue. Okay. Control other supplying arteries. Okay. Let's see what you get. Soft and small catheter. Hardens upon contact. Less predictable. Cannot be used with balloon. Reflux plug necessary. Longer injection time. control runs radiation cost. Oncogenic. Okay. It's just... We got fistulas, more fistulas. Coiling. Abnormal communication between the dural branches of intracranial artery and extracranial artery. So it's just fistulas. Fistula. Reflux. Reflux. Proptosis. Chemosis. Arterialized conjunctival vein. Ophthalmoplegia. Retroorbital pain. Intraocular pressure. Diminished vertebral artery. Oh. Okay. Transvenous approach. Ew, proptosis is, oh god. Progress. Oh, that's much better. Embolization of left CCF done. Acetazolamide with intraocular pressure controlled. Dexamethasone and eye drops. So it's just steroids, okay? Post-op. Residual left cranial nerve 6 palsy. Resolves retroorbital pain and chemosis. Walk-nated. Okay. Okay. All symptoms. Spetzler. Okay, I guess that's it for today, okay? I'll continue tomorrow. Bye. Finally done for today. I'll be going. Good night, all. Thank you for coming in.